Welcome back to the Means Report. Thank you for staying with us as we discuss aneurysms and learn more about the causes and what can be done about them. And thanks again to Anita Phillips for her compelling story. It struck me during the interview that we were at some points in the interview kind of just casually discussing something so very serious, but it's because of her outlook. She is so optimistic. She's so at ease with everything that's happened in her life, and I just found that very impressive. So let's learn more about aneurysms themselves, and I can't think of a better expert than Dr. Cargill Allen. Dr. Allen chairs the Department of Neurosurgery at the Medical College of Georgia at Augusta University, and he is a good man. Dr. Allen, thanks for being here.
Thanks for having me, Brad.
First of all, I found it surprising that 1 in 50 of us has an unruptured aneurysm. That sounds high and it sounds scary. Should we all be fearful?
Well, the good news is that although the incidence or the prevalence of aneurysms is relatively high, they don't tend to bleed very often.
Okay.
So there are only 30,000 ruptures that occur every year in North America.
Is bleeding better than rupturing, or is it the same thing?
Same thing.
You can't have like a slow bleed and be okay.
No, you could have a bleed that stops almost immediately, and that's called a sentinel bleed. And actually, a lot of patients will have a very minor headache and not realize that it's a sign of worse things to come.
I found something fascinating that I read about you when learning about the human brain, which is a 3-pound organ made of mostly water, and you called it the last great frontier. Why did you call it that?
Well, it's a very important organ, and it's amazingly, we know very little about the brain. So I think that most of the other organs in the body, we've got a lot of science behind what we do, but there's a lot to be learned in the treatment of brain diseases.
So here we have this organ with this life-sustaining network of vessels running through it. And your job, I think, is to try to find flaws in that network. What is an aneurysm? What are you looking for, and how do you know it when you see it?
Yeah. So an aneurysm is actually just a weak spot in the blood vessels in the brain, and it tends to occur at branch points in the brain. I brought a prop along just to help illustrate that. So if you can imagine a brain vessel that bifurcates or branches into two, with each heartbeat, it tends to wear away at the crotch here, the inner part of that branch point. And although most people aren't born with aneurysms, some of us are born with a weak spot in the wall.
What makes it weak? It just happens?
Yeah, some of it is genetics, and there's also other risk factors that can contribute. But that eventually develops into a small outpouching, and then that can eventually bleed.
What do you do to remedy it?
Well, historically, surgery is done, which is a formal open brain surgery where we identify the branches and the aneurysm under a powerful microscope, and then we apply a small clip to the neck of the aneurysm to prevent blood from filling that weakened blister. I do have an example of a clip here. It's almost like a metal clothespin that's designed to clamp the neck of the aneurysm and thus prevent blood from filling the aneurysm and causing it to rupture again.
So is your goal to restrict blood flow or to restore it?
It's actually to restrict blood flow into this bubble, which shouldn't be there at all.
All right, so the use of that portion of the vessel is gone. It's over.
Exactly.
And you just redirect the flow to the ones that work.
Exactly. Now there's a more modern way of treating aneurysms, and that's by going from the inside. So it's almost like doing a cardiac catheterization, where we go past the heart into the vessels in the neck, and then we extrude small, tiny coils made of platinum into that sac. And that basically fills up that sac with metal, and the blood that's swirling around ends up clotting off. So it becomes a dead sac of metal and coils.
Can robotics help you do your job, or is this all by hand, or both?
This is by hand, but we are looking at a screen when we do it from the inside, so we can actually see what we're doing on the screen as we work. And I do have an example of one of the coils. It's very soft, softer than your hair.
It looks like just string.
Exactly, because we don't want to actually rupture the aneurysm while we're fixing it. So it goes from the inside and then occludes that weakened spot.
You know, the same thing is happening during this interview as happened with Anita. We are so just casually discussing something so important and so scary. How long does this kind of procedure take? It's very delicate.
Yeah, it depends on the aneurysm and the complexity of the blood vessels, but it can take anywhere from 1 hour if you're calling a very small aneurysm to as long as 3 or 4 hours if it's a more complex procedure.
Dr. Allen, how do you diagnose an aneurysm? Is it just an MRI?
So an MRI is a good screening test to use, and in fact, in anyone that has a rupture, we advise that the family, the relatives, especially the first-degree relatives, get screened with an MRI scan if there's a history of ruptured aneurysm in the family. But the more definitive test is actually a cerebral angiogram, like I just described, which is a femoral study, and we inject dye from the tip of the catheter to look at the arterial tree in the brain.
What other risk factors other than family history have you noticed? Can gender play a role?
So women are slightly more likely to harbor aneurysms compared to men. Smoking history is a big risk factor, high blood pressure, diabetes, high cholesterol, and then the variety of other genetic disorders that can predispose to aneurysms.
If somebody meets some of those predispositions you just mentioned, or if they are practicing some of those lifestyles you rattled off, should they go get screened? In other words, should you not wait until a family history shows up or you have an aneurysm? Can somebody just go in and get a screening?
They certainly can. They can ask the family doctor to order an MRI or MRA, which will most likely show up a small aneurysm if they have it. If they have a family history, that's a little more compelling factor. And so if the family history is there, we definitely recommend that they be checked with an MRI or MRA.
How big does it have to be for you to worry about it or do something about it?
Well, the risk of bleeding is actually proportional to the size. So if someone has a very small aneurysm, meaning 1 or 2 millimeters, we generally just follow it. If the aneurysm approaches somewhere between 5 to 10 millimeters, then we generally advocate treating it. Some aneurysms are even larger than that, 10 to 25 millimeters, and the risk of rupture goes up sky high once it's over 25 millimeters.
What happens when an aneurysm bursts? Are there stroke-like symptoms? How would someone know?
So the most common symptom of a ruptured aneurysm is a sudden severe headache. That typically will render the patient incapacitated. Some people have a relatively mild headache, and those are the ones especially that may go undiagnosed. But they can also develop nausea, vomiting, weakness. Some people even fall into a coma. And unfortunately, 15% of patients actually die before they even reach a hospital.
Should you take an aspirin right away or not?
No, actually, an aspirin is good for a type of stroke where there's an obstruction of blood to the brain. Mm-hmm. This is actually a bleeding type of stroke.
And that would make it bleed worse.
Exactly. That could potentially prevent it from clotting.
If the unthinkable happens and someone's aneurysm ruptures, what, if any, lingering effects might they see? Or could patients return to near full function, as we witnessed with Anita?
So of the patients that survive a rupture, roughly half of patients will actually make it back to a meaningful, good lifestyle. Those that don't can have speech problems, difficulty with walking, sometimes difficulty with verbalizing or even thinking. But luckily, at least half of patients with a rupture will make a pretty good recovery.
You mentioned screenings and how, yes, people can just schedule one and get one. Is there an age that people should start to think maybe this is something I should consider?
So the age range for aneurysms tends to be in the 4th and 5th decades.
All right.
But to be honest, almost anyone can have an aneurysm. The youngest patient I treated was 6 months, and the oldest was a patient in his 90s.
Are there any medicines that we can take to help? And just as a follow-up to that, what kind of medicines do people who have had a rupture take?
So there's no magic pill to help prevent an aneurysm, but certainly there are medications that will help decrease the impact of the risk factors that I mentioned. So for instance, if someone has high blood pressure, they should definitely take their high blood pressure pills. If they have high cholesterol, they should take their cholesterol meds. If they're a smoker, obviously they should quit, since that would decrease the chance of the aneurysm growing and potentially rupturing.
At the risk of overlapping the worlds of neurology and neurosurgery, are there any exercises or things that we can do to sharpen the parts of our brain where an aneurysm might occur to decrease the risk?
No, as of now, there's no magic bullet, but certainly we advocate regular exercise because that can have benefits that will eventually result in the decreased risk factors that I mentioned.
Can we ever cure this?
Well, we certainly can cure it with the techniques that we have currently. Mm-hmm. I think in the future there are other devices that are being invented right now for more minimally invasive treatment. So in addition to the coils, there are certain types of stents which can cover the wall of the aneurysm without actually having to go into it. And so we do use some of those currently.
Yeah, you may have just answered the question, so forgive me for asking it. Is that where the research is focused, on equipment, on devices that can help you do your job more easily versus making sure there's never another aneurysm? Are you focusing on treatment?
Yeah, that's one arm of the research right now. The other arm is delving more into genetics of aneurysms. So we do know that there's a strong familial tendency in some patients, and so we're working on the exact genes that might predispose to having an aneurysm, because if we can identify that ahead of time, we may be able to identify patients who are more at risk for developing an aneurysm when they're 30 or 40 or 50.
When did you first get interested in this specialty? It's daunting to those of us on the outside looking in. When did your fascination with the human brain begin?
I think it was probably in medical school when we dissected the cadavers and saw just the intricacy of the blood vessels and the neural structures. And I also like working with my hands, so it seemed like a good marriage of the two likes.
Well, what about the feeling, Dr. Allen, when you have a successful case, when you see somebody go from being so fearful, so anxious, to returning to their life?
It's a terrific feeling. I mean, you really get to see patients who are near death's door and nurse them back to health. And you know, when someone is on the brink of death, I think you really have a life-changing experience that changes your entire outlook on life. So it's just, I'm very grateful to be a part of that.
Your outlook, I suspect, might not be that different from Anita, when she said, you know, everything is small stuff, you know, big picture-wise, everything's small stuff.
That's correct.
Dr. Cargill-Allen, thank you for what you and your team at MCG at AU do, and I really appreciate you taking the time today. I've learned a ton, and I know our viewers have as well.
You're very welcome. Thank you.
Absolutely. You're welcome back anytime. Neurosurgeon Dr. Cargill-Allen, what a wonderful job.